Good day, good evening, good morning to everyone joining us from different parts of the world. My name is Pacific 𝐮𝐻𝐽𝐬𝐲. I'm joining you from Rwanda. I serve as committee member from TORG-GET within the TORG Global Education and Training Committee. On behalf of the Operating Room Global and the TORG Global Education and Training Committee, I'm delighted to welcome you to today's global webinar. We are pleased to have you truly multidisciplinary audience with us today, including surgeon, anesthesia providers, nurses, surgical technologists, professionals, educators, researchers, students, and healthcare leaders. We are currently joined by participants from multiple countries across different time zones, and we sincerely appreciate your time and commitment to continuous learning. Whether you are joining us from Africa, Europe, Asia, the Middle East and Americas, or elsewhere, you are very welcome. Good morning to those joining early in the day, good afternoon to those joining in the middle of your day, and good evening to those joining us later. We are grateful to have you all. We strongly encourage active participation through the session. Please use the chat box to introduce yourself by sharing your name, professional title where applicable, and the country. Post your question and comment at any time during presentation. Our moderator team will be actively monitoring the chat and will bring your question forward during discussion segment. For those joining TORG session for the first time, the Operating Room Global is multidisciplinary professional platform representing over 260,000 surgical and preoperative professionals across more than 110 countries, making it the largest global network of the operating room professional worldwide. TORG brings about 42 healthcare disciplines and specialty currently, and operators not-for-profit and non-governmental organization founded in Nigeria in August 2015. Today, TORG has over 20 active chapters globally, including representation across 31 African countries. Our mission is to advance surgical and preoperative care through education, research, advocacy, innovation, and capacity building. We strongly focus on safety, equity, and system strengthening. TORG is international accredited continuous professional development CPD provider organized by CPD Group, underscoring the quality and global relevance for our education activity, and is supported by its academic innovation arm, the Operating Room Global Center for Education, Research, Innovation, incorporated in Ireland, which lead our global agenda in education, research, innovation, and partnership. Our affiliated journal, the Operating Room Journal, is open access, peer-reviewed international journal, inaugurated in May 2025, providing a platform for high-quality evidence that inform practice and policy worldwide. TORG is also proud to host its institutional review board, TORG-GET, officially registered within the USA Office of Human Research Protection, enforcing our commitment to ethical, responsible, and global credible research. TORG is driven by volunteer-led leadership model powered by passionate professionals who contribute their time, expertise, and vision to strengthen global surgical care. We are actively engaged with global alliances, including G4 Alliance, Intersurgeon, and listed with the Union of International Association, UIA, and global civil society database, reflecting our global accountability and reach. Thank you. You are welcome to this session. Thank you.
Thank you, Pacific. So good day, good evening, and good afternoon, distinguished colleagues and members of the Operating Room Global Community. My name is Dr. 𝐮𝐤𝐻𝐻𝐫, and it is my distinct pleasure to introduce our speaker for today's session on anesthesia challenges in obstetric surgery. We are honored to welcome Dr. Jackson Kwizera Ndekezi, an accomplished consultant anesthesiologist and medical educator. Dr. Ndekezi holds an MD and an MMEd, that is a Master's of Medical Education, reflecting both his clinical expertise and commitment to academic excellence. He is also a fellow in pain management at King Faisal Hospital, Rwanda, in Kigali, where he contributes to advancing perioperative and pain management practices within a leading tertiary institution. Dr. Ndekezi brings extensive experience in obstetric anesthesia, high-risk maternal care, perioperative safety, and multidisciplinary collaboration. His work addresses the complex anesthetic considerations involved in obstetric surgery, particularly within diverse and resource-variable healthcare environments. We are privileged to have him share his insights and practical expertise with us today. Please join me in warmly welcoming Dr. Jackson Kwizera Ndekezi. Please, Doctor, the floor is yours.
Thank you all for having me. Good morning, good afternoon, good evening to everyone from every corner of the world. And then it's my pleasure having you today. I'm trying to share my screen, and then it's on, let me know. And can you see my screen now?
Yes, sir.
Very good. So I'm very honored to have got this invite from Madam just inviting me to talk about this. When it goes to obstetric anesthesia, this is something that should be very serious in terms of what we do in our low and middle income countries. And then, with that, I think it was kind of pressure to just discuss this topic, being someone from sub-Saharan and specific to the Southern Hills country, Rwanda. So I don't have any disclosure in terms of funds for this presentation, but my innermost motives, that is discussing global challenges, inequities, and scalable solution to maternal mortality rates that are kind of striking now in our countries, and then thinking about bringing the global solutions to these in terms of maternal safety and anesthesia. With this picture again, we need to look at what is really the matter. We need to look at why global, that is most of the motives with TORG, and then why is it now going to North America, Nigeria, all of this. These are kind of topics or just some of the articles that I went through, and then this all will be giving us kind of insight on what we are going to be discussing. I just chose some of the articles that are discussing this kind of subject, and then at the end, we shall see why this matter. Why is obstetric anesthesia a matter to us, and then we shall see why the anesthesia provider on board when it comes to giving birth. And then we shall see some of the key challenges in obstetric surgery, and we shall see our context, LMICs, in terms of what we do have. And then I will share some of like what Rwanda has got so far in terms of the MDGs, SDGs, and then we shall look at the solutions and future directions. In the end, we shall have kind of discussion about every single aspect of this presentation. Now, globally, we know that there are maternal deaths annually. 200, around 290 maternal deaths per year. That is striking. That was in North America, in a publication from North America, and the numbers, 90% of all these maternal deaths occurred in sub-Saharan Africa and some of the countries in Middle East and Asia. And then the UN 2025 SDG target were to reduce maternal death to go below 70 deaths per 100 deliveries. Then in the end, we're going to see why safe anesthesia plays a crucial role in reducing overall maternal mortality. And then since 2000, with all the globally, with all efforts from every country, we saw that it started declining, but in the end, it kept a plateau at some point. So what are the causes? We shall see. It's again changing, or the causes are changing depending to where the patient is. That's where we have kind of disparities depending to where the patient is. So in developed worlds, it's more of comorbidities, but in our low and middle income countries, it's more of obstetric complications that are coming in front in terms of killing our pregnant ladies. Now, why obstetric anesthesia? Why anesthesia on board in terms of just reducing maternal mortality? So the anesthesia provider can be in terms of our patients when it comes to looking at pre-anesthesia or perinatal, and then we go all the way into theater and then post-op. And I thought might be regular wards, post-op recovery room, and then the ICU. And then here comes the critical care support that comes in our ICUs, HDU involvement, all of these. Then when we talk of operative status, we also need to do arrangements. And when it comes to obstetrics, the anesthesia provider can be helping in terms of labor analgesia that improves outcome in terms of who are going to be operated on or not. Then with all the efforts of bringing and then training in terms of obstetric anesthesia, they were all thinking about airway management and then managing all the obstetric complications or emergencies. We also need to think about hemodynamic stability and hemorrhage management that are already predictable in terms of who to give care. And then the anesthetists are needed in terms of giving anesthesia, of course. So the WFSA, which is the World Federation for the Societies of Anesthesiologists, recently in 2022 provided some of the recommendations of why the anesthesia should be part of the team in terms of maternal safety during childbirth. So their first recommendation was just talking about presence of the physician anesthetist, like each state maternal mortality review committee. So wherever, whatever, and whenever you're going to review maternal mortality, you need to bring in someone who is trained in anesthesia and then review what is going on. Then the 𝐮𝐻𝐽𝐻𝐬 from UK also contributed on this, and then they were recommending having a physician anesthetist as an active member of institutional, regional, or state level obstetric quality quality committees in terms of whatever we give, like care, acute care, special care into the hospital, in terms of obstetric care. Then during antenatal consultation, you may think about the anesthesia when someone has got high risk patients who are pregnant. That's where we start classifying the American Society of Anesthesiologists classification into the antenatal consultation. Recommendation about having a physician anesthetist. Of course, we shall see what really in context, what should be this recommendation in terms of context sensitivity. Then they were also recommending the presence of physician anesthetists in reading the implementation of elements of the American College of Obstetrics and Gynecology level of maternal care related to local and regional anesthesiology practice. Of course, it looks at the Society of Obstetricians, anesthesiologists, and of excellence elements that can be used to guide essential anesthesiology practice. Of course, they are kind of multidisciplinary looking at how the anesthesia should be on board during the maternal care related to local or regional anesthesia during surgeries or not. All hospital-based birthing centers should implement safety bundles and early warning systems, the scoring system that we use to classify or stratify patients' risks and everything. Ideally, implementation of these bundles and systems are just they are helpful to be read by the team, but in the end, having the physician anesthetist as a part of the leadership team. Again, they were recommending regular institutional multidisciplinary simulation for maternal emergencies in case, including teaching, planning by a physician anesthetist, or should include all of the members who work on labor and delivery, including anesthesia provider. As you can see, all these points are bringing in the role of anesthesia provider in terms of how they can reduce, they can play their role in reducing maternal mortality and severe maternal morbidity when it comes to giving care to these particular patients. Now, what are the key challenges that were kind of asked to me by Madam Founder? Prof, at the sort of way, I think thought about it because we are in kind of in limited or resource constraint settings. And when we talk about those settings, Sub-Saharan Africa and Asia, all of these countries, and maybe some of the countries in Latin America, they also think if thought to be kind of having all these challenges in terms of what we give. At the end, someone said maternal mortality is now less about what we know, biomedical knowledge, but more about health system inequity. Why this sentence? Why this assertion? It is because we think we knowledge and everything, but in the end, our system doesn't really support what we give to our obstetric patients. And then what we have like materials or equipment doesn't follow. They all should be the ideal world of where we give care to these particular. Then are we trained enough to get to the top point to give this care to these particular patients? The other thing is you may be trained, You may be having equipment, but in the end, do we have monitoring systems that really are alarming to us? I just inquired about early warning scores in whatever we do into our wards and everything. So with that, so it's more of health system inequity that is showing that maternal mortality is kind of. I have told you 90%, more than 90 of more than 90% of these cases are from sub-Saharan Africa. So with that, what are the challenges that we observe with this obstetric surgery? We think about workforce. We think about equipment, the drugs we use, access to health facilities. Is the training really helping to address these anesthesia challenges? The infrastructure that we have are really allowing our patients to get to where they need to be getting. So these are all the challenges we are going to be discussing into the next slide. So look, why the weak system supports obstetric anesthesia. The weaknesses are highlighted into red, and then we shall see some of the solutions that we can we can just work on to address the weakness that we can see. That we said the system is not really helpful. Look at the workforce shortages. I think to my latest knowledge, some of the Africans doesn't know have someone to give anesthesia. They are still depending on nurses who got some extra training like workshops, and in the end, they are giving anesthesia. Or the general practitioners are go scrub and come. Now, the other countries do have only non-physician anesthetists who are just trying their best to give care to the patients. They do not have physician anesthetists. Again, something like knowledge gap that are hinting on this one. So if we come up to some of the countries who got really worked on training physician anesthetists, they are still struggling to meet up the Rwanda Commission of anesthesia, because the Rwanda, we shall see what the Rwanda Commission does recommend to every country to have in terms of anesthesia providers. And then that is anesthesia providers in general. But in the end, there are no obstetric anesthesia provider in terms of what we do to obstetric patients. Then, so we have pride training centers in every country to make sure physician and non-physician anesthetists that are mission at least having the numbers that can go to the recommendation or the minimum required numbers to give care to patients, and particularly obstetric. We have limited monitoring equipment. This might be because these monitoring and equipment may be expensive at some point, but with a political way, sometimes you need someone who can inject or put some efforts to buy all these monitoring systems. But with the WHO and WFSA recommendation, they say at least you should be having at least the pulse oximeter, blood pressure, and EKG on every patient that is having at least regional or local regional anesthesia. But when it goes to general anesthesia, having capnograph with you. So how can we address that? Deploy essential monitoring including pulse oximetry and research with the capnograph to every patient that goes to sleep. Drug and blood supply. Some of the countries like Ghana, Rwanda, and I don't know if there is any other country that is using 𝐳-prime to supply blood. And recent drugs are being incorporated into the 𝐳-prime that are supplying drugs to the extent you do not get kind of cutoff or supply chain cutoff. So with that, you need to strengthen the supply chain for drugs and blood to all the centers or health facilities from the upper level to the local health centers. So we also have the delays. We've got delay to consultant, delay to treat. So all this will be addressed by having infrastructure that are really direction. They don't need to be miles and miles to get to the health facilities where they can get care. So we need to improve referral and transport systems. The other challenge is training and supervision gap. Jackson himself can't train more anesthesia alone, or Adepsera alone can't train the nursing workforce that is going to be covering the whole countries alone. So it's kind of multidisciplinary effort that is needed in terms of training and supervision gaps that needs to be addressed. With that, we've seen that simulation-based teaching, continuous training, professional development, kind of these webinars, and plus this emerging technology that are helping in terms of training people. The other thing is infrastructure failure, like power, oxygen, everything. I think this is not just only at the level of the government of local government helping that, but we also need to invest in reliable infrastructure that can be allowing an enhanced capacity building, availability of the infrastructure, oxygen, every healthcare facility that are really helping in terms of treating obstetric patients. To this, let me share you an experience that I got with a patient recently. Training went to a hospital in a remote this hospital. A colleague nurse gave birth in a normal way. It was scary. After giving birth, the lady got what we call postpartum hemorrhage. The hemorrhage she got was identified maybe later or not. That's something we need to, I didn't go into much. But in the end, the general practitioner needed to review the patient. But how to review the patient? He needed the patient to be a little bit sedated so that he goes in and review the uterus, maybe some bleeding or retained placenta parts, all of this. In there, the anesthetist realized there were no oxygen into that facility. So she was asking me, what can I do if there is no oxygen into this facility? The thing is, to me, my advice was just have an IV line, blood transfusion, give tranexamic acid, prepare the ambulance, and go to the nearby hospital where they do have oxygen for them to review the patient. And then I also told the GP to pack the uterus. But in the end, don't ask me about what happened maybe in the later days. So now, in the end, we need something like like audit. What happens if we are dealing with marriages, but in the end there are no governmental will in terms of the implication for obstetric anesthesia. We need obstetric audits, and then its implication in terms of obstetric anesthesia. And then what you can do is you just realize there is something that is missing. You can measure. Of course, you need to have data, analyze them. Of course, after analyzing, you identify the deficiencies. After identifying the deficiencies, you can just put up recommendation and actionable something like solutions that you can just use. And then you do again the audit what is going on, set standards or evidence based that are documented in terms of delivering the obstetric anesthesia. Did obstetric anesthesia improve something in terms of what we give to our birthing mothers? If yes, did these measures been improving the way we give care to laboring moms during delivery? If yes, you keep it. What can we change so to make everything smooth? Anymore? As you can see, this year's cycle that it keeps changing with the way we evaluate the system as we move forward. Now, look at the way the trends in our MICs comes to our way. So we still have fewer anesthetists. This is a study that was conducted in East, South, and Central Africa region. And this study revealed that many of the factors that are limiting obstetric anesthesia contribution was fewer anesthetic providers. And then we also had high patient load. And then the other thing was underfunding of anesthetic services. Because some of the things they think like surgeons are the best, the things that you can just invest in, but in the end they forget there is a system that is kind of behind the surgeon who needs again to be supported in terms of to deliver the best care in terms of surgery. Lack of local protocol and guidelines for the patient management, shortage of blood and blood products for transfusion. Again, you can see that the risk mentioned factor was purely service to equipment. As you can see, we do not have like something that is contributing to maternal mortality. That is most striking, like fewer anesthesia providers, high patient loads, underfunding of the training, local protocols and guidelines that are missing. So we need to kind of talk about this when it comes to helping our settings. Then with the advent of medical career and then care, as you can see, we still have patient complex cases that are coming to us, mental health in developed world, racial disparities in the outcome, and geographic and socio-economic barriers that we found to be kind of something that determines the mortality in recent studies. The WHO also showed that new tools in the safety toolkits of the clinician should be using or renewed focus on maintaining the standards of care. When the other thing is the novel solutions that are being used to personalize risk stratification, coordinate early intervention, managing scarce resources. These are all missing in our LMIC countries. Then there is critical staff shortage, inadequate equipment, infrastructure limitations, and high-risk patient presentation. These all we discussed in the previous slides. An experience to our country, Rwanda. So those who have never been in Rwanda, we do have kind of highlight in terms of referring patients from lower level to the upper level. I think the same in many countries worldwide. But in the end, what do we have at the top of our health system? There is the Ministry of Health, and then we've got under the Ministry of Health, there is a referral board that can allow a patient to go outside of the country. And then we do have teaching hospitals that are referred level 1 teaching hospitals, and then we do have level 2 teaching hospitals. And then from that, we have district hospitals, and then we do have private hospitals with specialized care to patients. Those are the hospitals that are like into private, but partnering with the government. We also have health sectors or health centers that are readily available in every sector. And then we have what we call dispensaries that are readily available into every village. And then with that, on top of having this kind of organized health system, you can skip one level and then you get to the next level if you're using what we call our community-based health insurance. This is a kind of government funded community insurance scheme that is allowing everyone to have access to care within 30 minutes wherever you are in the country here in Rwanda. So it's something that has been helping in improving maternal mortality rates. And then the goal were to have to drop from 203 and then go to 105 by 2029 maternal mortality. And right, so with that, we thought under this health sector strategic plan to be working. Where are we now? The challenges were the same as all the countries in LMICs, where you have systemic gap, staff shortage, sometimes drugs and access to them. But some of the challenges that I highlighted in the previous slides were addressed by the government. Now, how about the status now? The recent DHS, which is kind of development and health census by the government, the Rwandan statistics, they published a recent report that showed that we have now maternal mortality rates of 149 over 1,000 live mothers that are going to give birth, which shows an improvement. Can we meet the goal of having 105 by 2029? I don't know. We just under brackets. In the end, we still work on it with the help of the government, having everyone on board. Now, what were the lessons or the achievements that helped to achieving all these numbers? We do have what we call community health workers. These are the people who didn't get any training in terms of healthcare, but they get kind of courses in terms of very common health issues, and they can help treat those or depict those issues into the local community and they report to the health centers nearby them. So these are the people who have been helping in terms of depicting who is pregnant. If you're pregnant, she can or he can go and report or even accompany to the health center. And then if she says you that your due date is almost approaching, he will accompany to the health centers to stay there when you give birth, be attended. Then we do have the this community insurance that is covering everyone. And then this reduces the delays in consulting, delays in consultations and everything, and delays in getting medical consults and help. Then here comes the zip line. 𝐮𝐻 has been helping in delivering blood wherever in the country, and I think the farthest part of the country, you may get like 30 to 45 minutes to get blood from the distribution centers. And then this 𝐮𝐻 has been helping also to give emergency drugs all over the country. You need like fainting, being far away from Kigali, you may get it like 30 minutes wherever you are in the country. And then in the end, everyone is held accountable. The government made sure everyone needs to be held accountable in terms of what you should be doing and the timing that these things should be done on time. And then there is projection. We do have what we call 4x4 strategy, which is a strategy from the Ministry of Health that is aiming to control the existing of health care by, and then we have these SDG goals, and then we have this with the SDG goal, we aim to reduce the maternal mortality rates by up to 50 per 100,000 live births by 2050. So why did I bring these future directions? As you can look at the pictures here, except that the United States of America, most part of the Europe, Australia, these are all the countries that achieved to be having readily available obstetric anesthesiologist or the anesthesia provider during deliveries of 20 and more providers. Now, when you go to per green, you can see some of the countries like in Latin America, South Africa, still into Europe and Canada. And these are the countries who can be having 10 to 15 providers of anesthesia into the labor room or into their facilities to help with deliveries. So for you, as it's alarming, look at the African countries. Only maybe the North Africa and South Africa, maybe some of the Senegal and Asia, some parts of Asia can achieve to be having 3 to 6 trained obstetric anesthesia providers. So when it comes to Africa, which is very alarming, you can see that you can even have less than one provider that can give safe obstetric anesthesia. Why? Think about working on these challenges. The Randstad Commission on Global Surgery, we're targeting to have 20 surgeons, obstetricians, and anesthesia providers for 100,000 population by 2030 to reduce the mortality gap. Or wherever you are, you can now think about what are the numbers in your country. And then it's kind of brainstorming on what should be done. Then it also, the future direction also again works on reducing the anesthesia-related mortality with all the impact of having the team multidisciplinary approach of the obstetric patient. Training and education, quality of care that we give to the patient that is associated with evidence-based medicine, and then having high-risk patient identification and stratification, where the anesthesia provider should be on board into the antenatal consultation, mainly to the patient who are at high risk. And then look at having global maternal mortality rates decline as a goal in every country. And then I think this should be my last slide. If then when I'm done. And then to conclude, we need to invest in workforce, infrastructure, and training to make sure we just come up to cover the basics and then obstetric anesthesia, address all the challenges. We need to integrate anesthesia into the national surgical plans and specifically for obstetric anesthesia. Again, of course, we can't sit down and then just say we have our policy and everything. We need to look at leveraging global partnerships, having people around to help teaching, training, updating our SOPs, guidelines, and everything. And in the end, no woman should die giving birth. No woman should be dying while giving life. Thank you so much. If there is any question, these were the references I used.
It is my pleasure to introduce Lieutenant Colonel Olufemi Olatunji, a distinguished Chief Nurse Executive with the 540th Aeromedical Staging Squadron of the United States Air Force. Lieutenant Colonel Olatunji is a medical surgical registered nurse, legal nurse consultant, and public health practitioner with extensive experience in clinical leadership, military healthcare system, and patient-centered care. He is also a combat veteran, bringing a wealth of real-world experience in high-pressure, complex healthcare environment. Currently serving in the Reserve Nurse Corps at McGuire Air Force Base, New Jersey, he has demonstrated strong leadership in advancing nurse practice, operational readiness, and multidisciplinary collaboration. In addition to his clinical and leadership roles, he is an aspiring attorney, further expanding his expertise at the intersection of healthcare policy and law. We are delighted to welcome Lieutenant Colonel Olufemi to his session, where he will be speaking on inspiring change and fostering innovation in nursing leadership. So welcome, and the session is yours. Thank you.
Good afternoon, good evening, everyone. Good morning. Can you hear me? Hello?
Yes, please.
Okay, sorry about that.
Great. Thank you.
You're welcome. Sorry about that. So the last point I made was, what is the importance of leadership in nursing? That is, you want to lead by example, by building strong teams and empowering others to reach their full potential, thereby improving the quality of healthcare system and ecosystem. So let's look at some types of leadership or nursing leadership styles. The first one is what we call authoritarian, autocratic leadership, democratic leadership, transformational leadership, laissez-faire leadership, servant leadership, situational leadership, transactional leadership, and systematic leadership. So when you say autocracy, it's very much explicit. That is top-down and decisive. In other words, autocratic leadership can be very efficient in a kind of emergency situation whereby you have to make a critical decision just right on the spot. That's when you can use that kind of approach, but it's not the best. Democratic is collaborative. In other words, you're seeking buy-in from other stakeholders. Just like when talking about democracy in politics, you want to get buy-in from everybody involved so that you can be able to empower them, you collaborate with them. That is democratic leadership. Transformational leadership is visionary. In other words, you project into the future. You're going to take time to set goals, do a gap analysis study and stuff like that, so that you want to be able to carry everybody along and empower them to get your mission, vision, and goal aligned together for you to achieve the objectives that is set. Laissez-faire leadership is kind of hands-off approach. You kind of empower your subordinates to take risk, but must be calculated risk taking. You don't want to give them free hands or free reign just to do anything, and then there's going to be some adverse consequences as a result of that. So you're not going to be macro-managing them or micromanaging. either way. But again, you want to empower them to be able to take their own initiatives so that they can develop and bring up new ideas. Servant leadership. That is, you are oriented towards the needs of your staff and members. You gear towards ensuring their needs are met. That is, whatever they need to function effectively, you are more into that. Situational leadership. That is just in time or on the spot, based on circumstances. In the military, we call it critical thinking, out of the box style. Whatever situation presents, that's what will determine the kind of leadership that you're going to evolve at that point in time. Transactional leadership. That's when you use incentives to reward performance. Somebody is doing very well, you give them something to actually motivate them to do better. So that is transactional leadership. And I think I have, 1 second. Strategic leadership. That is the latest in town now, because you're talking more about CPI, continuous process improvement. In medical sciences, we call it evidence-based approach or research. So everything is data-driven. You want to bring a lot of brains together. You keep reevaluating everything that is being done to make sure that nothing is being dropped. In other words, you want to do better next time. For example, in the medical practice settings now, we do what we call hurdles. After an event, we go back and do what we call debriefing, so that we want to see what we did very well and what we need to improve upon next time the situation presents, so that we can be better at what we are doing. That is what we're talking about strategic leadership. Why is nursing leadership important? Nurses are the cornerstone of any healthcare organization. Nurses spend 24 hours by the bedside. I'm sorry, with no point intended. Physicians will come and rotate. They are specialists coming and seeing patients, but they don't stay by the bedside with the patient for 24 hours. So nurses can give everything about the patient from A to Z versus other providers. So that's why leadership in nursing is very important, to make sure that patients are getting the best. Effective nurse leadership is critical for strengthening integration of safe, effective, and high-quality patient care. Very straightforward. When the leaders are going astray, obviously the followers are going to follow. They're going to follow suit, and everything is going to be chaotic. We don't want that to happen in a very high-risk environment like healthcare settings. So, good nursing leadership is very critical to ensuring effective, safe, and high-quality patient care. And nursing leadership constitutes a core element of professional development. That is very straightforward as well. So let's look at some leadership theories in healthcare. I have here 6 theories of leadership: the great man theory, the trait theory, behavioral theory, transactional leadership theory, transformational leadership theory, and contingency theory. Great man theory, one of the earliest leadership theories, posits that leaders are inherently born with certain traits that make them natural leaders. According to this theory, these individuals possess extraordinary qualities such as charisma, intelligence, wisdom, and courage, which distinguish them from others and enable them to shape history and lead effectively. This theory suggests that leadership is not something that can be learned or developed. Rather, it's a characteristic that individuals either possess at birth or they do not have it. Why this has been influential in the past, this theory has been largely discredited in modern leadership studies, because in healthcare, where leadership is seen as a set of skills that can be learned and developed rather than innate traits that only a select few possess. In other words, this theory has been discredited because leaders are not born. Even though people say that, but you can still acquire good leadership skills. So it is not something innate that you are born with. You might have some qualities that might help you to be a better leader in future, but this theory automatically does not mean that once you come from a royalty, for example, a royal family, you must be a good leader to rule a community or something like that. That doesn't make sense. It doesn't really work like that. So it's been discredited. The trait theory. The trait theory builds upon the foundation of the great man theory, proposing that certain personality traits are key indicators of leadership potential. This theory, developed in the early 20th century, asserts that individuals who possess specific traits such as self-confidence, decisiveness, integrity, and intelligence are more likely to be effective leaders. Unlike the great man theory, which focuses on the inherent nature of leadership, the trait theory suggests that these leadership traits can be identified and measured. However, like the great man theory, there are limitations as well with this theory. which include assumption that leadership qualities are fixed and cannot be learned. In healthcare, where the ability to adapt and respond to complex changing environment is crucial, this theory does not fully account for the dynamic nature of effective leadership. You can see the difference between the two. Then we move to behavioral theory. Behavioral theory marks a shift from focusing on inherent traits to examining the behaviors and actions of leaders. According to this theory, leadership is not about who you are, but what you do. Leaders can be made through learning and experience, and effective leadership is a result of specific behaviors that can be observed, that can be taught, and can be replicated. This theory suggests that anyone can become a leader given the resources, the right environment. If they learn the right behaviors, like I said, such as effective communication, decision-making skills, and the ability to inspire and motivate others. In the context of healthcare, this theory is particularly relevant because it supports the idea that leadership can be developed through education, training, and practice. You can see the distinction there. The next one is transactional leadership theory. Transactional leadership is based on a system of rewards and punishments to achieve desired behaviors and outcomes, which is called contingency management. This focuses on the exchanges between leaders and followers, where leaders provide resources or rewards in return for compliance and performance. This style is often associated with management rather than leadership, and is most effective in situations where tasks are routine and goals are very clear. In healthcare, transactional leadership might be used in environments that require strict adherence to protocols and guidelines, such as in administrative or operational settings. However, it might not be sufficient in environments that require innovation and adaptability. Transformational leadership theory is characterized by the ability of leaders to inspire and motivate followers to achieve more than what is expected of them, that is, going above and beyond. Transformational leaders focus on the big picture, articulating a vision that inspires others to work towards shared goals. They are often seen as change agents who encourage innovation, foster a positive organizational culture, and motivate followers to exceed their own expectations. In healthcare, transformational leadership is particularly valuable as it helps to navigate the complexities of healthcare delivery, drives improvements in patient care, and foster a collaborative and supportive work environment. Contingency theory. Contingency theory posits that there is no one-size-fits-all approach to leadership. Instead, the effectiveness of a leadership style is contingent on various factors, including the situation, the task at hand, and the characteristics of the followers. This theory suggests that successful leaders are those who can adapt their style to the specific needs of the situation. In healthcare, where leaders often face a wide range of challenges, from managing crisis to leading change initiatives, the ability to adapt their leadership approach based on the context is critical for success. We can all see this during the era of COVID-19 epidemic. We were able to adapt based on the prevailing circumstances. So, in summary of all these theories, transformational leadership theory and contingency theory hold strong results for the contemporary times. However, I want to say that the takeaway is this: any of these leadership theories can suit whatever situation you find yourself, aside from the first two, because they are kind of archaic, if I can use that word. Behavioral theory, transactional leadership theory, transformational leadership theory, and contingency theory, they are still evolving, and you can blend them together to become a very good and successful leader that others can emulate. That will be my takeaway from there. What is the distinction between management and leadership? Management involves planning and budgeting, but leadership involves setting a direction. Management involves organizing and serving, while leadership involves aligning or bringing people together. Different skill sets, but you bring them together so they can achieve a common objective. Management provides control and solves problems, whereas leadership provides motivation and inspiration. So these are the key distinctions between management and leadership so that we don't get confused. Management and leadership, they are two different things, but they may align together in terms of achieving goals and objectives. What are the qualities of an effective nurse leader? An effective nurse leader must possess what we call EI, emotional intelligence and empathy, effective communication, integrity and trustworthiness, clinical competence and critical thinking skills, visibility and approachability, adaptability and problem solving, and lastly, mentorship and empowerment. What is EHI? Somebody who is emotionally intelligent will not draw conclusions rashly. You have to look at the extenuating circumstances before you can come at a conclusion. And you are not the one that is going to get angry unnecessarily. You're not going to be partial. You're going to be open to your subordinates. You give everybody a level playing opportunity so they can achieve their maximum potential. That's somebody who is emotionally intelligent as the leader. You must show empathy. In other words, you're putting yourselves in your subordinate's position. So you're not going to be that lot up there while your subordinates are like your servants. No, you put yourself in their situation so that you can actually feel what they are feeling. Their pain is your pain, their suffering is your suffering. Effective communication. For you to be an effective nurse leader, you must be able to communicate effectively. Skill of articulation is very important. In the military, we are used to what we call, if you are giving commands as a leader, people cannot understand what you're saying. You're not supposed to be in that particular command role. So you must be able to communicate effectively as a nurse leader. Somebody with integrity and who is trustworthy. I mean, your word is your bond. When you say hey, your hey should be hey any time of the day, whether you're under anesthesia, whether you're awake, whatever situation you find yourself, you must be a person of integrity to be able to lead effectively. And you must be trustworthy. Clinical competence and critical thinking. Again, what you don't have, you can't give. For you to lead others who are performing clinical skills, you must be competent by yourself. Otherwise, you're not what that to be in that role. The ability to think critically, as I've said earlier, you're going to deal with so many situations that will bring about thinking critically to achieve your objectives in terms of patient safety and efficient patient care. So a good nurse leader or an effective nurse leader must be someone who's imbued with good critical thinking skills and capabilities. Visibility and approachability. Again, open door policy. You must be visible to your subordinate teams. They must see you readily, whether in the spirit or in the person, because they know that you're there for them to support them. And you must be very approachable, sociable, even though with some caveats. Adaptability and problem solving. In the military, again, we are used to ability to survive and operate under austere circumstances. Situations will change. There'll be limited supplies, resources, and all that. As a leader, you must be able to adapt and inculcate that adaptability skill into your subordinates so they can function effectively. Then, problem solving. As a good leader or effective nurse leader, you must be able to troubleshoot things and problem solve effectively. And lastly, you must be a good mentor, a coach, model, and must be able to empower your subordinates so that they can grow, they can develop, and they can actually take your role when you retire. That is what we call succession planning. An effective leader must be visionary. In other words, they are thinking about the future. I'm going to retire. Anything can happen. I can be sick. I can be on vacation. Anything can happen. They already start planning who is going to succeed them. That is a good and effective nurse leader in terms of looking at the paradigm of healthcare practice as an organization, because you're not going to be there. Whether you're there or not, operations continue. So you must be able to articulate that very well to mentor and coach other people so that they can be empowered to take the reins when you are not there for whatever reason, and then life continues in the environment. So what are the attributes of an ineffective nurse leader? Reverse now. Poor communicator. They lack emotional intelligence. They often thrive with micromanagement and other controlling behaviors. They are the kind that will bring other people, they call it divide and rule tactics. Somebody will come and report something to them. They won't be able to bring them together to clarify what exactly happened so they can be a neutral arbiter between them to make sure there is no kind of toxicity in the work environment. Such an effective person, they lack support and they don't really engage in terms of development activities of their subordinates. Oftentimes, they are very abusive and they manifest toxic behaviors. They're very poor decision makers and they are very rigid. And most times, when you see people like that, the environment is going to be hostile to both the patients and the staff. They are very self-centered. They don't care about anybody else but themselves. Now, let's look at purposeful leadership in nursing. What is purposeful leadership? Purposeful leadership often offers action alignment and strategic decisions embedded in deeply held commitments towards safe, efficient, and cost-effective patient care. And this PL embraces core nursing values of compassion in each nurse's personal mission. In other words, as a leader, you want to make sure that you're driving a purpose in your subordinates. What is the purpose? Safe, effective, efficient, cost-effective patient care. That is the mission. Unless you communicate that purpose to your team, you're not going to lead them very well. So that is the essence of purposeful leadership. PL involves a deliberate effort to inspire, to coach, to mentor, to model, and guide others toward the attainment of a shared vision or mission, which goes beyond mere task management or assignments. It's not just teaching the patient, the nurses to give shots or to administer medications. It goes beyond that. It's building a long-lasting relationship with the patient to make sure that they don't get readmitted frequently back to the hospital. What are the key or core components of purposeful leadership? Number one, advocacy and influence for both patients and nursing staff. You're advocating for the patients as well as advocating for your staff. Because in my culture, I'm from Nigeria originally, Yoruba culture. If you don't feed, sorry, there's a common saying in English now. He who pays the piper, takes the tune. If you're going to advocate well for your staff, obviously they're going to get the best for the patient. So overall, everybody's going to benefit 100%. Empowerment and support in development. Key, very important. You want to invest as a leader or purposeful leader into developing your staff and subordinates professionally. Continue education programs, advanced educational degrees. They are just starting with associate degree as a nurse. Encourage them to go for bachelor's degree, master's degree, doctorate, and what have you. There are so many tracks you can actually steer them towards to becoming an accomplished professional. Career leader initiatives. I don't know if you're familiar with that, but we have that in America. What called career leader initiative is that you're going to have a kind of career succession planning for your subordinate staff, from being a staff nurse, novice staff, experienced and all that, to expert. So there's a kind of program for them to make sure they go through these ladders so they can actually develop and be fulfilled. Then you give opportunities for growth and development, resilience and compassion. A purposeful leader must show empathy, as I've said earlier, and must offer programs or resources that will help their other people, subordinate staff, to deal with high stress and incidents of burnout. Nursing is very much high stress job. And for you to be a purposeful leader, you must be cognizant of that fact that you make available programs and resources in and out of workspaces that can help your staff members deal with stress so they can be able to function optimally whenever they come to work. Vision and inspiration. A carefully articulated vision for both patients and staff is very important for you to be a purposeful leader. So we must create and maintain an environment that is considered therapeutic for both patients and staff. Then value-based decision making, which includes empathy, integrity, advocacy. They are the most important things to ensure safe, effective, and efficient patient care and mitigate risk. Things like sentinel events, near misses and stuff like that, medication errors. If the environment is actually geared towards making sure that the staff members are able to function well, that is, you empathize with them, there is a risk, the risk level there will be reduced versus when we are open to all this kind of high stress environment with no resources to help them mitigate those kind of stress factors. So that is the point I'm trying to convey there. So how do we discipline as a leader? Again, discipline should not be misconstrued as something that is negative. But it becomes a problem when discipline becomes something to destroy your subordinate staffs. We are all humans. There's a common saying, to err is human, but to forgive is divine. In my practice as a leader over the years, I've always believed that as a professional nurse that works for me or works under me, you don't wake up in the morning to go to work or to show up at work with intent to injure a patient. But like I said, we are all humans. Any number of things could have happened before you get to your workplace. So that's when we try to look at what we call progressive discipline. In other words, okay, we're not going to let you go because you made an error, but we still want to make sure that you are corrected so that you can prevent future occurrence. So we're talking about levels of disciplinary actions, which can include progressive discipline, verbal warning, written warning, and terminal, which could be up to termination of the person's employment. Then we use CAP, what we call correction action plan. In other words, when somebody made an error as a nurse, as a good leader, you bring them to the office, you talk to them, try to look at the whole picture. We're not going to be judgmental. We want to see what we can do again to improve their performance and their professional skills such that that error does not get repeated. We can use IDP, individualized development plan, as well to correct things like that. Then when there are major things that happen, like a major medication error, God forbid, life involved or anything like that, we have to do what we call RCAs, root cause analysis. So that is very intense too. But even then, we still want to give them the benefit of the doubt that they don't come to work to just deliberately injure somebody. But the essence of this is to make sure that we don't have a reoccurrence of such in the future. And then when we do this, we educate other people across that immediate environment. It goes kind of global. Okay, somebody will reference to RC that happened about so and so in another hospital. So that's the learning environment or a learning tool for other people so that they don't make such errors again when that happens. Then reprimand or censor. I mean, that's higher level now. When things are being done repeatedly and this person is not changing, we may have to reprimand them or actually censor them. Then probation. Sometimes people might have to be put on probation because of an error they have committed that could be very egregious. At a point, we may have to report them to the Board of Nursing. They may restrict their practice license or they may actually withdraw the license. Suspension, then revocation can be a last resort. So they can no longer be considered safe professionals at that point. They have to find something else to do because we've tried everything to make sure that we get the best out of them, but they have not really been able to, adapt. So at that point, to save the public, we have to make sure something is done to actually take them off the practice and then they can do something else they enjoy very well. So how do we build a lasting legacy as a leader? Again, you want to empower others. You want to create a robust succession planning, as I've said over and over. Coaching and mentoring, very important because you're going to model people that will succeed you and you can only give what you have. So if you're not a good leader, you cannot train others to become a very good leader like you are. Encouraging advanced education and professional certifications. I'm sorry, in the United States, we talk about so many types of educational opportunities. Masters, postmasters, what have you, and then different plethora of certifications, specialty certifications with rewards and incentives to encourage people to actually pursue those ones. Then providing rewards for excellence. We have so many awards that we actually give to people to motivate other people so they can perform as well to that level of achieving that kind of recognition. Engaging in evidence-based practice and promoting research. We cannot really do without evidence-based practice and research. So it's very important we invest into research and encourage our subordinates to do that as well. So what are the key strategies to inspire change and foster innovation? Number one, establishing psychological safety and culture. You want to empower and engage your staff, provide resources and infrastructure, leveraging mentorship and education, as I've said, recognizing and rewarding innovation, and leading with vision and adaptability. And there are some actionable steps for nurse leaders to inspire change and foster innovation. You want to start very small. It doesn't have to be a big research project, just very small steps, baby steps. Focus on burnout, listen actively as a leader, and then utilizing data to actually bring about whatever change you want to put in place in the work environment. So in a nutshell, I want to close by giving you leadership as an acronym to go away with this. L is leading with purpose. E, emotional intelligence. A, assertiveness. D, dedication. E, empowerment. R, responsiveness. S, strength. H, honesty. I, integrity and innovation. And P, prioritization. And obviously, poor leadership can bring about toxic work environment, reduced patient safety, high staff turnover, and patient outcomes like increased length of stay can actually be adversely impacting the hospital's resources, especially in America. And that concluded my presentation. Are there questions? Thank you.
Thank you, Dr. Olatunji. I think that was an excellent talk on the various aspects of leadership, where you not only gave us some valuable tips, which I'm sure are going to help all our upcoming young leaders in healthcare. And I really loved the last slide where you have beautifully summed up all your tips and takeaway messages from your talk.
Thank you so
So the
much.
house is now, pleasure. The house is now open for the question and answer sessions. And I would like to request and encourage all of them on behalf to our both our speakers. So just to set the ball rolling, Dr. Olatunji, I would like to pose a question to you. So knowing that healthcare innovation actually nursing leader effectively while aligning with the surgeons
The connection is
hierarchical
poor.
healthcare system.
Can you repeat the question? I cannot hear you. There was poor connection.
Okay, sure. Go ahead. I'll repeat my question again. So what I wanted to know was that since healthcare innovation basically requires a multidisciplinary collaboration,
Yes.
so how can a nursing leader actually drive this innovation? While aligning with the physicians, the surgeons, the hospital administrators in a classically hierarchical healthcare system. There's a lot of
Oh, thank you
hierarchy
so
in the
much.
hospital. Yeah.
Okay. Thank you so much. I think that's a very valid point. But you look at the scope, like what I'm used to in America, we work in multidisciplinary environments whereby we have the chief nurse officer or the chief nursing officer or nurse executive, chief medical officer, chief of pharmacy, all the disciplines. We come together to rub minds. Nobody actually is going to be the lead. We have to, everybody's input is actually solicited to make sure that we have a common goal towards achieving our mission for the hospital or the healthcare system. So everybody's input is well respected and it's very important. So we're not going to discount anybody's expertise. Nurses, surgeons, what have you, pharmacists, everybody comes together to work together to achieving the goal of effective leadership in the entire healthcare ecosystem. So that's the approach.
Excellent. Thank you.
You're welcome.
Thank you. So, Dr. Jackson? Is Dr. Jackson there with us?
Yeah, I'm there. I'm around.
Yeah. So, a question for you, Dr. Jackson. You have wonderfully described all the various aspects of anesthesia in obstetrics. So the question was like with the increasing complexity of the obstetric patients which we come across nowadays, now because of high BMI or it could be advanced age or multiple prior surgical procedures already been done on that patient. So what do you think is the best evolving, the biggest evolving challenge which the anesthetists of today, they face in obstetric surgeries and which they're going to face over the next decade or so as our patients become, you know, uh, more elderly and probably have more comorbidities?
Thank you. Should I say Bapnix? Bala.
Yeah, that's correct. That's
Yes.
correct.
It's a very good question actually, and responding to it will depend to where someone is. But addressing obstetric anesthesia challenges might be something we need to start by pre-op or during antenatal consultation, pre-anesthesia based intraoperative, and then post-op. That is in terms of clinics. Then the other thing is having government way to improve in terms of workforce development, because we need first to look at the basics, basic basic care to a pregnant lady in the end, and then what is now most advanced comes to when we have these complex cases of obstetrics having these big BMIs, cardiac comorbidities, respiratory stuff like. So awaiting the training efforts of every country. But again, thinking about simulation-based training, you start working on like shanks. You just train your stuff about something like lateral positioning or airway management. Very striking obstetric emergencies. covering them with kind of regular courses, simulation can help the existing staff numbers. And then after that, we also need to make sure we've got again inputs from the teaching institutions. Of course, if you're working on your existing number of staff, again, you need to partner with the teaching institutions. Again, as I said, you need partnership with the other countries' experts. If I was to be having people being invited to my country, if Bara was obstetric anesthesiologist, that would be my first target to invite you, come and share the knowledge with my existing team. That's the way we can work on. And then when it comes to low and middle income countries, again, much efforts on non-physician anesthetists plus physician anesthetists being trained in terms, don't leave anyone behind. The other thing that is going to be upon the Minister of Health in every country is now bringing on the same table the anesthesia providers in terms of maternal health. At some point, we think that the obstetrician, maybe gynecologists are the best in giving such a care, which might be true. But in the end, you need a nurse, you need anesthesia providers, you need biomedical technicians, you need everyone on board to make sure you give what we call holistic care to the obstetric patient. I don't know if I responded very well, but it's like political will and addressing the challenges and working on workforce development, the existing and training the other people joining the thing. Then as long as you train people, or of course you tackle these complex cases that are coming to you. But in the end, clinical-wise, pre-anesthesia during the antenatal consultations, intraoperatively and post-operatively. Thank you so much.
Thank you, Dr. Jackson. Excellent. So one more question which I've
You're
always been,
welcome.
intrigued about, and if you may allow, I wanted to ask you. I'm not a obstetrician. I'm a surgeon by training, but I always think about that, and I think this is a good opportunity to ask and get an answer from a seasoned anesthetist like you. So in a case of a truly emergency C-section, in that particular scenario, how do you, as an anesthetist, how do you balance the urgency of the procedure with the need to optimize the maternal anesthetic, preparation of the patient?
That's again a very good question. The thing is, we have categories of emergency in terms of cesarean section. There is category 1 that needs to be delivering the baby within 30 minutes. And then there are 1 hour used to have some time, or 1 hour and a half having sometimes. And then when it goes to 2 hours, it's no longer emergency. It goes to elective, something like. But you go all the way categorizing the urgency and emergency status of the case. So when it comes to being super emergent case, it's all having the existing anesthesia staff that is always available, readily available at any time of giving care to any obstetric patient. That means every healthcare facility that is giving care to birthing moms, they should be having the anesthesia team that is readily available into the service. So when the obstetric surgeon calls, you're available. And then at some point, we also have to be ready with the emergency equipment. The equipment readily available equipment, the anesthesia, the nursing, all this equipment available to handle. That's the way. In fact, you need human resources, materials, equipment, the anesthesia machines and every monitoring, and plus the neonatologist. If you do not have neonatologists, at least have a very good trained pediatrician who can be helping in terms of neonatal resuscitation.
Thank you, Dr. Jackson. Thank you. That
You're
explains it
welcome.
very well.
Thank you, Dr. Thank you, Dr. Boni, for question and answer session. Actually, we need to wind up so far.
Please go ahead. Please go ahead.
Yeah.
I think there are no more questions, so we can give the vote of thanks. Please go ahead.
Thank you. So, on behalf of the whole operating room global, I would like to sincerely thank you to our distinguished speaker for their valuable insight and all the participants for joining us today from different countries, time zone, and professional backgrounds. We really appreciate our participation despite their busy clinical schedule, varying internet access, and language difference. Your commitment to continuous learning and improving surgical and perioperative care in your local setting is commendable. We encourage you to share the key lesson from the 2-day session within your team, institutions, and professional network to help strengthen safe and effective practice globally. We also invite you to stay connected with our community through our upcoming webinar, training programs, and research activities on our official platform. So, to receive your accredited training certificate, please remember to complete the evaluation and certification form, which will be available for 24 hours after this session. Certificate will also be issued within 5 to 7 working days upon successful submission. Thank you once again for being a part of today's session. We wish you a safe and productive day ahead, wherever you are joining from. We look forward to seeing you in our future session. Thank you.
Thank you.